Good afternoon, everyone. I'm Michael McGinnis from the National Academy of Medicine here in Washington, D.C. And I say good afternoon, although I realize that for some of our viewers and participants, it's still the morning on the West Coast. But welcome to everyone. This is a meeting that is sponsored by the National Academy of Medicine, and we work in partnership with the Health and Medicine Division of the National Research Council, and we're focused on financing that rewards better health and well-being. And we're delighted to have all of you who've been able to join us. This is perhaps one of the most critical issues of the day across the board. It certainly is among the most critical in the health and medicine arena. If I can have my first slide, please. I want to draw attention to, if you can keep going, certainly fast through that one, there we go. I want to draw your attention in particular to the tagline to financing that rewards better health and well-being. It says, efficiency, effectiveness, equity, and experience implications of integrated payments for health. This is an important element of our meeting today and the subsequent two meetings, because it gives us two starting points for the conversation. Starting point number one is that it's very clear that our system falls far short on the issues of efficiency, effectiveness, equity, and patient and family experience. That's undisputed. Secondly, the second starting point is that there is virtual agreement that our fee-for-service platform is not working. We need to change the way we go about paying for health and health care in this nation. And note that I said health and health care, because the two are intertwined, not only in how they shape the health and well-being of the population, but in the strategies that need to be engaged in order to improve the human condition throughout the nation. I want to give special thanks right at the outset, not only to all of you who've joined us, but next slide, please, to our workshop planning committee. This meeting series, and as I mentioned, there are 3 meetings that we'll be having, has been planned by a stellar group of individuals and leaders and experts from throughout the nation. Our co-chairs are Keisha Davis, who is Vice President of Health Equity at ALDAID, Mai Pham, who is the President and CEO of the Institute for Exceptional Care. And on the panel, along with Keisha and Mai, are Andy Beinman, who's Executive Vice President and Chief Medical Officer at Kaiser Foundation Health Plan, Stephen Cha, former Chief Medical Officer for United Healthcare for Community and States. He's now joined the administration. Margaret Chesney, Professor of Medicine at the University of California at San Francisco. Dina Chisholm, Director of the Center for Child Health Equity and Outcomes at Nationwide Children's Hospital. Chris Kohler, President of the Milbank Memorial Fund. Peter Long, Senior Vice President at Blue Shield of California. Josh Sharfstein, Vice Dean and Professor at Johns Hopkins School of Public Health. Sarah Zanton, Professor of Health Equity and Social Justice at Johns Hopkins Nursing. Many of you have heard of these individuals. Some of you have worked with them. I can assure you who haven't been engaged with them previously that we have a simply extraordinary group of individuals to work with us in this planning activity. I want to just give you a little bit of context from the perspective of the National Academy of Medicine that's bringing us to the session today and over the following 2 days. Next slide, please. At the outset of the COVID-19 pandemic, about a year ago, the NAM Leadership Consortium, which is comprised of leading national stakeholders from 9 different sectors in our health system, mobilized the leaders from those sectors who were members of the consortium to reach out to their colleagues, other leaders within the sector, in order to assess the damage that was being done, the problems that were being encountered by COVID-19. And the interest there was twofold. One, to identify ways in which we can enhance our response in each of the sectors, but also to identify broad health system changes that were being revealed as important mandates through the course of the pandemic that need to be engaged. Next slide, please. You see that the sector assessments in these 9 sectors were led by a fairly extraordinary group of individuals on their own. Patients, Families, and Consumer sector was led by the CEO of Families USA, the CEO of the AAMC, and the Director for Health Transitions at the University of Pennsylvania. I won't go through them all because you can read them as easily as I can, but I will point out the sectors: clinicians and professional societies, care delivery organizations, digital health, state and local public health, health payers, health product manufacturers and innovators, health and biomedical research, and quality and safety standards. So the important thing to underscore here is that in each of these arenas, from patients to clinicians, digital health, state and local public health, all the way through, a dominant common feature of the challenges was the nature of our health payment system. It was left people exposed into inequities. It led to fragmentation and difficulty in developing an integrated response. It led to disjunctures in the ability to identify the nature of the problems in real time. Our payment system has led to fragmentation throughout the system that is our dominant challenge in health and healthcare today. Hence our interest in ensuring through this series of meetings that we not focus on identifying the nature of the problem so much as focus on the issue of the solutions. Next slide, please. There are a series of simultaneous activities underway here in the national academies that are related to integrated payments for health. And I will run through these quickly just to underscore the fact that we view this as an extremely high priority for the nation. I've already mentioned the COVID-19 priorities for health system transformation. We also have worked with CMMI on issues that are priority for their contributions to catalyzing change in the health system. And we have one of the CMMI leaders, Dawn Alley, speaking with us later in the course of the meeting. Vital directions for health and healthcare priorities for 2021 is our quadrennial report to the nation, and underscored in that report was the need for changes in health costs and financing. We have a session that has spun off from our report released last week on primary care, a session coming up later on the issue of payment for primary care. And finally, we have a focus on a collaboration between healthcare and public health. Next slide, please. So our agenda today is this: to focus on action, what it is we need to do to move our system toward a more integrated payment enterprise, and collaboration, what we need to do together, who has to be engaged as key leaders in the process. Next slide, please. I want to give special mention and thanks to our workshop sponsors. A number of the representatives from each of the sponsors is with us today, but I'll just mention one for each of them as an example. The George Family Foundation is represented by Gail Ober. The Nemours Foundation is represented by Kara Walker, who you're going to hear from also later on today. The Samueli Foundation by Wayne Jonas, who I should say and underscore was a principal proponent of our partnership in this workshop series, and also involved, along with the other colleagues, in the follow-up. The Wellbeing Trust, which is represented by Benjamin Miller, and the Whole Health Institute by James Marzoff. So we have, I think, a very timely, certainly well-organized session, and it's now my pleasure to introduce our two co-chairs. Next slide, please. Our co-chairs, as I mentioned earlier, are Keisha Davis, who is a family physician and community health advocate. She serves as Vice President of Health Equity, as I mentioned, at ALDAID, as a commissioner of MACPAC, and previously served as a medical director of CHI Healthcare, and was also a White House Fellow, I should mention. Also, Dr. Mai Pham is co-chair of the Planning Committee. She's a general internist and president and CEO of the Institute for Exceptional Care, which is a nonprofit organization focused on transforming healthcare for people with intellectual and developmental disabilities. She previously served as the Chief Innovation Officer at the CMS Innovation Center and Vice President at Anthem, where she made major contributions to the fields of payment policy and value-based care. Keisha and it's my pleasure to turn it over to you. I believe, Keisha, you're going to lead off, and thanks again to all of you.
Thank you so much, Michael, for that introduction. And thanks to everybody for joining us this afternoon and this morning. For those of you who are out on the West Coast, we are really excited to bring this conference to you. And just want to start off with sharing appreciation for the committee who has helped to bring such a great panel of speakers that we have to share with you over the next several days, next several sessions. So I want to just start by outlining the goal of the meeting and some of the objectives that we have to cover with you all over this series. And the goal is really, as Michael laid it out, to facilitate the identification and adoption of health financing that delivers value and optimizes the achievement of the fundamental goal of health and healthcare, assuring that the population and each individual reaches their full potential for health and well-being. And I really want to emphasize not just the identification of those models, but the adoption of healthcare financing that's delivering value. We really want to get to beyond just identifying what's wrong with the current system. Yes, we want to have some, blue sky, what's the next thing that would be great, but really, how do we start to put that into action with an eye towards whole health and well-being, not fragmented healthcare? How do we stop that system and really look to expand and better that? And so we have 4 objectives for the conference. The first is understanding the deficiencies of the current healthcare delivery and financing system. Second is considering alternatives by identifying examples of payment and delivery models that advance equity in health outcomes for populations, improve patient and clinician experiences, and reduce per capita costs. Third, identifying barriers and opportunities to scaling effective integrated payment models and approaches. And fourth, discussing specific strategies, levers, and stakeholder responsibilities to transform health financing approaches from fee-for-service to integrated payment approaches that incentivize, again, a whole person health and population health perspective. And so, so many of the events over the course of this last year have really highlighted the health inequities. The pandemic showcased that inequity that we see, especially across racial lines. We've seen a decrease in U.S. life expectancy over the last year. And in conjunction, what also has been on display is the failings of the fee-for-service financing model. It has been just major shortfalls in how we think about paying for care and incentivizing the right payment for patients, the right reimbursement for providers. And so this really elevates and indicates that critical need for accelerated transformation and the financing that we need, those financing models that reward better health and well-being for all Americans, even in the face of public health crises. So I want to lay that out as the foundation of what we're going to cover over the next 3 sessions. And I'm going to toss it to my co-chair, Dr. Mai Pham, to review the structure and logistics for the coming days.
Thank you so much, Keisha. And let me just add my welcome to all participants and my gratitude to Keisha and Michael, the NAM team, as well as all of the planning committee members. This was a lot of work to pull together to share with you today. So there will be, we hope, a natural narrative arc flowing through the 3 days. In the first day, we hope to provide a vision for what integrated health and healthcare delivery could look like and what the financing system could look like that supports that. Day 2 will examine specific innovative models and specific levers that were underscored during the pandemic as having particular promise for getting us to whole person and community health. And the third day will provide a forward-looking roadmap of new approaches that may be extremely ambitious to getting us to better efficiency and effectiveness and equity. Each of those days will feature 3 panels consisting of a moderated discussion between leaders from arenas of care delivery, from health financing, as well as planning committee members. Each day will also include 1 short innovation spotlight, which is our desire to elevate awareness of particular bright spots around the country where clinical organizations have really done remarkable work pushing the envelope in addressing whole health. And we hope that those spotlights will give you a sense of what practical action can look like. So let me also help to set context here by defining what we mean by whole person health and population health, and also provide an additional framing in terms of the kinds of patients and people we have in mind as we go through these conversations. The committee took on this work under the premise that whole person population health represents care delivery models that place particular priority on certain things. First, on advancing health through health promotion and disease prevention, while also, of course, ensuring high quality evidence-based treatment when needed. Care that supports and reinforces the importance of equitably enhancing health and well-being for the entire population within communities. Care that is person-centered rather than provider-centered. Care that is relationship-based rather than transaction-based. Care that is holistic, integrated, and integrative, and continuous rather than fragmented and episodic. And care that utilizes accountability mechanisms and metrics that matter most to the people, the families, and the populations we're trying to serve, and that can guide the direction of new processes and structures in a learning health system that will deliver better health and higher quality, lower costs, as well as optimizing the experience, the care experience for both patients and clinicians. So as we do this work, we found it useful on the planning committee to imagine for ourselves several archetypes of patients that we wanted to keep in mind as we move through these conversations, because these are, if you will, the end users of any ideas that come out of this exercise. And we want to make sure that we stay grounded in their realities and their needs. So for example, Jamal is a 10-year-old with seasonal allergies, asthma, as well as ADHD. He's a really good soccer player, but he can't always get to his inhalers and has had to miss several games and practices. His primary care provider has recommended counseling and dietary supplements, as well as medication for his ADHD. But his parents are hesitant to start medication and they can't afford the supplements. They haven't had much success in finding a therapist to accept their insurance, and they can't afford to pay out of pocket. He does have health insurance through the Children's Health Insurance Program. Margarita is a 45-year-old mother of two who works full-time as a private duty home care nurse, but she's often working at night and available to a family during the day. She also has a primary caregiver for her. She's also a primary caregiver for her elderly parents, and her mother was recently diagnosed with Alzheimer's. She has a BMI of 33 with pre-diabetes and mild hypertension, and her doctor has recommended improving her diet, getting exercise, and quite a bit of weight loss. But her sleep is poor, and she rarely is able to find the time to exercise. She's covered by a high deductible insurance plan through her employer. And lastly, Mr. Chen is an 85-year-old widower who lives alone with his children far away in a neighboring county, although they do manage to visit him weekly. He's very clear that he wants to retain his independence, that's a high priority for him. He relies mostly on frozen meals, and his daughter worries that he's losing weight. He's got peripheral vascular disease and neuropathy, as well as macular degeneration. He's had several fall risks in his home, and his doctors recommended changing his diet as well as gait training. He's often had to cancel his appointments for eye treatments when his children aren't available to take him, and he can no longer drive himself. He is covered by a Medicare Advantage plan. So we really encourage you and all of the panelists to keep those archetypes in mind. They represent real people with real needs, and we want to stay grounded in those realities. Let me just review a little bit some of the logistics and housekeeping items for the workshop as well. First, we would encourage you to use the chat function in Zoom to add any comments or questions. The team will be continually monitoring that, and it will help us to feed questions into the discussion. We want to highlight that we are recording this workshop, and copies of these presentations and slides will be available after the event.